You know just as well as I that you have seen implants deintegrate because of a chunk of cement somebody has inadvertently left when cementing a crown. Well, that's changed. We should not be cementing crowns like that, where the dentist cements the crown over an abutment. In that case, the abutment is zirconia. Why? Because how in the world do you get all that cement out of there? I don't know how many of these I've done and then radiographed and thought, wow, I got a big chunk of cement in as hard as a rock. How am I going to get it out? As you look at that image, you can see very clearly how much cement someone has left around that implant. And you'll also see the implant's a goner. That's the image on the right is the actual implant. Unbelievable why we did that. There are other ways to do it. There's another one exactly the same way. That's one where one of our local practitioners had done the implant, and the patient somehow got over to me eventually for a second opinion, and I could actually rotate that slightly in the bone, and you can see the chunk of cement that was left around it. It's a real frustration, though, because now you have to decide, if I take that out, I'm going to have a lot of bone loss. Can I graft vertically? You can see that the bone loss has gone down, a third of the way as you compare it with the contiguous teeth. Should I try to graft that and do another implant? In that case, we did. But that's a hard decision. You cannot make bone grow vertically. You can make it grow facial-lingually. I shouldn't say you cannot, but it's quite an exotic technique and a long time and a good pile of money. Would I be better in that situation just to do a typical 3-unit fixed prosthesis? And the answer is probably yes. Well, how have we overcome cement? How have we overcome that little problem? On the left, you see a situation such as we just talked about, where the dentist cements the crown over a screwed-on abutment. What's wrong with that? Well, what's wrong with it is they come loose 10 or 15% of the time, according to the research, and then you have no access to it. You have to try to take it off, and occasionally you have to cut it off. Not good at all. So that's been done now for a long time. You may not know, implants started out without any anti-rotational features in it. And there was a lawsuit on that because one person had a patent on it and others could not make the anti-rotational feature for years. And finally, there are anti-rotational features in every one of them. Now, look at the right-hand side. In this case, the technician in the laboratory has cemented the crown over the metal abutment. Does it have to be metal? No, it could be zirconia, it could be anything. And then the screw goes down through the hole in the crown and the hole in the abutment. Where's the cement? There is no cement. Now, most of you are doing this technique, but you may not know how important it is for the laboratory technician to know the proper technique. As they cement the crown over the abutment, the cement wants to fill the access hole, so they have to put something in the access hole to preclude that happening. Then when they have to decide what cement to use, may I strongly suggest you look at the two adjacent teeth. As soon as you cement that crown, which has improper contour, because you cannot make proper contour on an implant. They're always a bulbous coronal and a little toadstool apical. So what? They collect food in apically, and the chance of caries on those adjacent teeth is very high. Therefore, cement with what? A karyostatic cement, not a resin cement. The lab tech should be cementing with resin, modified glass ionomer. Current popular brand names are Relax Luting Plus and GC Evolve. Well, what have I said? That has been a very changed concept over what probably many of you were doing. Make sure the laboratory technique is done properly, and if it comes loose, unscrew it. and put a new screw in and put a composite plug in the top. Pretty simple. Thanks for being with us. Join us next week.